Hello, everyone. Hope you all are doing well today. An approach will be discussed too easily. Acute breathlessness is the most common symptoms of many patients and get admitted into emergency department. So, I will discuss about the easy approach to acute breathlessness of medicine ward. I will not mention about traumatic causes of breathlessness. See the last till the video end. Hope you get benefited. Let's get started. When a patient comes with acute breathlessness, all must assess the important signs, and they are saturation of oxygen, blood pressure, pulse, anemia, cyanosis, and lastly, auscultation of lung. Then 3 investigations has to be done immediately by 3 equipments. ECG by portable ECG machine, chest X-ray by portable X-ray machine, and RBS by glucometer. By the way, don't forget to give oxygen to the patient while doing these procedures. While doing these procedures, as a physician, you have to first exclude 3 dangerous, life-threatening causes of acute breathlessness, and they are airway obstruction by foreign body, tension pneumothorax, and anaphylaxis. For the diagnosis of airway obstruction by foreign body, ask patient about inhalation of any object. When you auscultate the lung fields, you may not hear lung sounds unilaterally or bilaterally. Percussion note may be found dull. On the other hand, patient with tension pneumothorax will present with peripheral chest pain along with breathlessness. On auscultation, unilateral lung sounds will be absent. Trachea will shift to opposite side and percussion note become hyperresonant. On chest X-ray, the first photo shows a foreign body as the object is radio-opaque. Otherwise, for radiolucent, history and clinical findings are enough to reach the diagnosis. For management, immediate bronchoscopy needed. In the second photo, there is a clean-cut, collapsed lung margin, and absent bronchovascular markings on right side confirm the diagnosis of tension pneumothorax of right side. In this case, urgent chest decompression by blood-set needle is mandatory to relieve the patient from breathlessness. The third life-threatening cause of acute breathlessness is anaphylaxis. History of insect bite, food allergy or drug intake along with angioedema, malar flush, urticaria, visible mark of insect bite, itching of hands and feet, hypotension and wheeze on auscultation of lung fields confirm the diagnosis of anaphylaxis. Immediate introduction of fluids, hydrocortisone, and adrenaline improves the condition of the patient. Now take a look of a patient of anaphylaxis. Next, exclude pulmonary embolism for cause of acute breathlessness. History of syncope, chest pain, and hypotension with history of major surgery such as hip, spine, or femur surgery within 7 days, history of DVT, prolonged air travel, or unilateral leg pain and swelling are suggestive of pulmonary embolism. On doing ECG as chest pain present, it shows a S1Q3T3 pattern. Take a look of ECG and chest X-ray of pulmonary embolism. Now we reach to the most common cause of acute breathlessness, the acute exacerbation of COPD. The patient usually ages greater than 40 years, smokes greater than 10 pack per year. His or her chest is barrel-shaped. On auscultation, prolonged expiration with wheeze is the classical finding. ECG shows tall P wave called P pulmonale and right axis deviation present in most of the time. On chest X-ray, enlarged lung, flattened diaphragm, tubular-shaped heart shadow, and increased intercostal space is noted. Acute severe asthma is another common cause of acute breathlessness. Usually, patients have been suffering from occasional breathlessness from childhood when exposure occurs to some triggers like dust, pollen grains. They usually give no history of smoking. On auscultation of chest, the lung sound is prolonged expiration with wheeze. When pulse 110, respiratory rate 25 and can't complete sentence in one breath represents the severe symptoms. Nowadays, due to COVID-19, acute respiratory distress syndrome is very common. SpO2 falls continuously, even with 15 liters per minute oxygen supply. Chest X-ray is indicative of the diagnosis. Now we move on to the cardiovascular cause of acute breathlessness. First of all, myocardial infarction with acute left ventricular failure causes acute breathlessness. Patient also has central chest pain, sweating, and fear of impending death. On auscultation, bilateral crepitations are heard. ECG may show ST elevation, an obvious sign of myocardial infarction, as well as chest X-ray reveals pleural effusion, prominent hilar vessels, Curley's B-line, reticular shadowing, and enlarged cardiac diameter. RX include propped-up position, furosemide, and IV nitroglycerin. Sometimes patient with chronic heart failure may present with acute breathlessness. Bilateral crepitations, peripheral edema, raised JVP, tender hepatomegaly are the obvious sign of acute on chronic heart failure. ECG shows poor progression of R wave suggestive of old myocardial infarction. Mnemonic MDMS is the protocol of treatment. Cardiac arrhythmia can cause acute breathlessness. Patient complains palpitations. On examination, irregular pulse and a mitral stenotic murmur may be found. ECG shows a typical arrhythmic pattern. Next, the most missing cause of acute breathlessness is anemic heart failure. On examination, severe anemia is noted and bilateral creps are found. Furosemide IV nitroglycerin and transfusion of packed cell volume improves the patient condition. Very interestingly, a metabolic disorder, the diabetic ketoacidosis, DKA, causes acute breathlessness. Dehydration, high blood sugar, abdominal pain, nausea, and vomiting are the other signs and symptoms. Psychogenic breathlessness is the last cause in this section. Usually young female patient having previous episodes whose SpO2 doesn't fall without oxygen. Other signs and symptoms are carpopetal spasm and digital and perioral dysesthesia. Hope everyone listens the video carefully and note them thoroughly. Apply them in practical aspect. Hope you will find it works.